It's my pleasure to welcome you to day 2 of the End-Stage Renal Disease National Coordinating Center National Patient and Family Engagement Learning and Action Network Summit, Patients Charting Their Own Path. My name is Stephanie Hull, and I'm a member of the ESRD NCC team. Also on the phone today with me is Jerome Bailey and Tara McAdoo. I hope many of you were here yesterday. We had a wonderful discussion and a wonderful program, so we welcome you back. If not, to the others who didn't attend yesterday, thank you for being here. I think you'll find it a really good interactive day today. We have some great speakers also. You will be hearing and learning from people just like you who will share their kidney disease journey. You'll also be hearing some from professionals and patients on a variety of topics. The patient voice is essential to the work of the CMS and the ESRD NCC. Your input allows us the opportunity to provide quality care for those living with and affected by kidney disease. I also want to thank CMS for collaborating with the ESRD NCC and the patient volunteers for the hosting of this program. Next slide. A few items just before we get into the summit. The call is being recorded. All participants upon entry into this meeting have been on mute, but everybody is encouraged to use the chat feature located in the bottom right hand of your screen for submitting questions and comments. We do want to hear from everybody today. And so I just want to take a moment to say, let's practice. Go down to the chat. You might see a little icon. It looks like a little bubble. Thank you, and type in your first name and where you're from so we can see. And I see Lisa. Thank you, Lisa. Stephanie Dixon. Janet from Alabama. Ruben from Brownsville. Jerome, St. Pete. Jerome. Jesse, great. Kathy from Alabama. Tony B. Beretta. Okay, great. Just want to make sure everybody's comfortable and knows where to submit any of your questions or just comments as we go through today's presentation. So you don't have to wait till the end. If you think of somebody, a question or comment for the speaker, please go ahead and put in, and we'll have time at the end of each presentation to kind of look at the chat and ask those questions. Next slide. So just a little bit of what our agenda looks like today. We're kicking it off here. We have 3 different sessions. We will be taking about a 5-minute break in between each one, give you a little bit of time to stretch out, get a little food and water. And then we'll just, again, as I mentioned, we'll have a little time at the end of each presentation for some Q&As via the chat. And so that will give you an opportunity to ask any questions. So I think the next slide. So our first presentation today is Overcoming Mistrust in Healthcare. We have 3 speakers today. I'll introduce them now. We have Darcy Graves. Darcy joined the Centers for Medicare and Medicaid Services Office of Minority Health in 2015. In her current role as acting technical advisor, she leads the CMS Health Equity Technical Assistance Program, which provides strategic hands-on guidance to individuals and organizations seeking to embed health equity into their policies, programs, and initiatives. We also have Dawn Edwards. Dawn is the CEO of New York State CKD Champions, which is the advocacy and education group she was instrumental in founding. Dawn was diagnosed with kidney disease in 1992 and is currently using nocturnal home hemodialysis. Dawn's biggest accomplishments was reinventing herself after mastering home hemodialysis, starting the New York State CKD Champions, and re-entering the workforce as a home dialysis advocate. We also have today is Derek Forfang. Derek has been a type 1 diabetic since age 10 and an ESRD patient since 1999, utilizing various treatment modalities, including transplantation, peritoneal dialysis, and in-center hemodialysis. Derek is the chair of the National Forum of the ESRD Networks, Kidney Patient Advisory Council, member of the Forum Board of Directors. He is also the chair of HSAG ESRD Network 17's Patient Advisory Committee and chairs the Network 17 Board of Directors. He serves as chair of the National Kidney Foundation Kidney Advocacy Committee and chairs the NKF Public Policy Committee. He also is a member of the Kidney Health Initiative Patient and Family Partnership Council. Please welcome our first presenters for this morning. And I'm going to turn it back over to Darcy to start us.
Thank you so much, Stephanie, and thank you everyone for being here today. I'm very excited to be on this panel, and I'm really looking forward to hearing from Dawn and Derek. So I want to get through my portion as quickly as possible, because I think that's really where the heart of so much of this is. But good afternoon and good morning, depending on where you are. As Stephanie said, my name is Darcy Graves, and I'm with the CMS Office of Minority Health. I have spent the better part of my career helping health and healthcare professionals, healthcare systems, adopt and implement culturally and linguistically appropriate services in the hopes to help make the system, interactions, communications, much more respectful and responsive to those that the individuals or organizations are serving. During that time, I have also been a patient, a caregiver, and an advocate for myself and my family members. The healthcare system can be a daunting place under the best of circumstances, but rarely do we interact with the system under those circumstances. It is never more daunting than when you are feeling weak, sick, tired, etc. And when this is coupled with mistrust, or when those who are entering it are carrying misinformation, well, the results can be devastating. Today, I'm going to provide some background on the issues of mistrust and misinformation, what may contribute to it, how we can measure it, and how it might manifest itself in clinical encounters, so that you know how to recognize it. I will talk a little bit about some of the ways to overcome mistrust and misinformation. But as I said, I'm most eager for you to hear from your colleagues, Derek and Dawn, on how healthcare professionals can better earn the trust of patients. Next slide, please. But before we get to all of that, a little bit of background about our office at CMS. Next slide. There are numerous offices dedicated to minority health and health equity within the Department of Health and Human Services, or HHS. On this slide, you can see the agencies that have offices of either minority health, health equity, sometimes health disparities. They all have slightly different titles, but all with primarily the same mission. But the agencies that include such offices are the Agency for Healthcare Research and Quality, the Centers for Disease Control and Prevention, the Centers for Medicare and Medicaid Services, which I come from, Food and Drug Administration, Health Research and Services Administration, the National Institutes of Health, the HHS Office of Minority Health, and the Substance Abuse and Mental Health Services Administration. All of these agencies and all of these offices are all working to advance health equity, which is to help individuals attain their highest level of health. Next slide, please. I won't read or belabor this slide, but I do want to highlight that the CMS Office of Minority Health's vision is that all those served by CMS have achieved their highest level of health and well-being, and that we have eliminated disparities in healthcare quality and access. As you may know, CMS is a very large player in the healthcare system. We help provide coverage, access to insurance to over 1 in 3 Americans, or approximately 150 million people in the United States. Next slide, please. Our office is dedicated to making sure that everyone achieves their highest attainment of health, but we focus on a number of populations that have disproportionately been faced with disparities or inequities, and that includes racial and ethnic minorities, people with disabilities, members of the lesbian, gay, bisexual, transgender, and queer communities, or the LGBTQ communities, individuals with limited English proficiency, individuals residing in rural communities, and persons otherwise adversely affected by persistent poverty or inequality. Next slide. And now I want to talk a little bit about how we will work together to operationalize health equity and what we are aiming to do this year and for at least the next 10 years, and how every one of you listening and watching can work with us toward this shared goal. This slide speaks to our anchor and our true north as we carve a path to equity across our healthcare system. Our guiding lights are the communities we represent, the voices and perspectives of those we serve. We have decades of research to draw on to learn about the needs, barriers, and opportunities, about pressing and emerging disparities among members of our communities. But we also continue to seek to understand firsthand what the most critical needs are and what our partners in and serving our communities felt CMS could do to have the most impact on health equity and eliminating disparities locally. From these focused listening sessions to members of our communities, we have set out to operationalize the agency's strategic pillar of advancing equity, and in partnership with all of our communities, individuals, and those that we serve. And this means that we have taken time and energy to focus and deepen our engagement with stakeholders across programs, including the LANs and the affinity groups and all of those where we have patient volunteers. Identify areas of focus that are most important to those communities and align existing CMS and HHS initiatives and work to build on success and fill gaps. Next slide. Last slide before we actually get to the topic of mistrust. The COVID-19 pandemic has shone a light on so many of the disparities that we already knew existed, but has brought this to bear on a whole new level for so many individuals who weren't previously aware of the ongoing disparities and inequities. So with that in mind, we'll go to the next slide and start talking about some definitions and provide some background on medical mistrust and misinformation. Next slide. Medical mistrust is the absence of trust that healthcare providers and organizations genuinely care for patients' interests, that they're not honest, practice confidentiality, and have the competence to produce the best results possible. Next slide. Medical mistrust describes a patient's sentiments towards the medical system in general. Medical distrust concerns a patient's sentiments towards a specific actor in the system, i.e., a specific provider. And a patient may distrust a single physician, but still trust the broader medical system, but can still trust that the broader medical system is actually acting in their best interests. Knowing where the distrust or mistrust lies is important when we get to the point where we are able to address and try to mitigate that mistrust or distrust. Next slide. The relationship between mistrust and misinformation. Misinformation can be defined as false information that is believed to be true, usually spread without malicious intent, which differs from disinformation, which is spread with the intention to deceive. We've seen a lot of both over the last few years. And again, it's important to understand the difference, because medical mistrust can foster misinformation by leading individuals to seek information from possibly unreliable sources rather than healthcare professionals. We've all seen the headlines and have seen too much in the last few years that undergird those concepts. Next slide. In the next couple of slides, I want to focus on mistrust, what contributes to mistrust across a variety of populations, how we can think about measuring mistrust, and how mistrust can manifest. Like, what does that look like in real life beyond someone saying, I really don't trust you? So figuring out what that is. So next slide. So here are 5 possible contributors to medical mistrust. There are probably others, just focusing on these for a moment. But generally, historical injustices, which many of us are all too familiar with, refer to the nation's record of colonization, enslavement, institutionalization, and the other isms across the board, including how these systemic injustices are embedded in our healthcare system. I think most of us are probably familiar with the Tuskegee syphilis study and the Gila immortal cell line research that is based on, the work, I'll say the work that Henrietta Lex did for us, but was not aware of or privy to in terms of information. And there are other, the Barrow alcohol study and diabetes studies that have impacted numerous populations across the board. Moving down to the second row, provider bias and discrimination. Generally, discrimination refers to providers' negative assumptions, whether implicit or explicit, again, across populations. This, belief that people with disabilities experience a lower quality of life and therefore influence of that belief during emergency situations or crisis standards of care. You hear anecdotal stories. There was an NPR article that in the days after Hurricane Katrina in 2005, doctors and staff at a medical center in the New Orleans area when generators, lights, and sewage went out, first rescued patients who could walk. Again, disenfranchising, further marginalizing populations that shouldn't be marginalized and further stigmatized. Moving to stigma. Generally, stigma refers to the social process through which individuals affected by certain health conditions are labeled, stereotyped, and considered to be other than the norm. We see this frequently in sexual orientation or gender identity. Research suggests that members of the LGBTQ plus communities delay care because they often feel unwelcome in healthcare settings. Those in rural locations, and that can be inclusive of frontier and tribal locations, fear stigma and discrimination from healthcare providers and other community members related to a perceived lack of privacy, which may result in delayed care. We hear anecdotal stories again where folks in rural areas choose not to go to a clinic that offers behavioral health services because if they see your vehicle out front, if your neighbors see their vehicle out front, they all know that Darcy has gone to get that kind of help, and that may not be culturally relevant or culturally appreciated in that area. Again, specifically we see this again with the mental health care and medication for opioid use disorder treatments. There's also, yes, and I see information coming into the chat about additional barriers. There are also structural barriers that refer to challenges that priority populations may encounter when seeking care, such as a lack of providers, financial inaccessibility, or language barriers. We talked a little bit about, we mentioned individuals with limited English proficiency, having a lack of trained and culturally appropriate and culturally competent interpreters for individuals who live with limited English proficiency is a huge barrier and burden for individuals who speak English less than very well. A lack of appropriate accommodations for people with disabilities. This not only means wheelchair accessibility, but making sure that there is a scale that can accommodate people who have equipment that travel with them, or being able to have a mammography machine that allows individuals in wheelchairs to have the screenings that they need, all of those sorts of pieces. Provider shortages, particularly in rural areas. We know that healthcare provider shortage areas are particularly poignant in those areas. Language and literacy barriers contribute to both medical avoidance and misunderstanding of medical information, which can also perpetuate misinformation. And then additional structural barriers include a lack of appropriate accommodations that perpetuate mistrust with provider and systems that have one's best needs in mind. Those related to physical access to care, for example, due to provider shortages in rural areas, which can be adversely affect trust building and contribute to mistrust. Generally, this refers to the fact that individuals from diverse cultural and religious backgrounds may find it difficult to trust a provider who does not share their background or who may not appear to understand their background. And this includes cultural differences between patients and their providers and cultural and religious norms about sexual health behaviors and other types of interactions. Next slide. I didn't want to dwell just on all of the root causes of medical mistrust because I think we all, so many of us, most of us know why it is a thing. There have been horrible instances and the mistrust has been earned, but now we need to figure out how to collectively do better so that we can all do better. I just wanted to share this medical mistrust index because I think it gives some perspective on different ways to think about where mistrust can manifest, how mistrust could be measured, if that is something that your healthcare organization or if you're a healthcare provider, you want your clinic to undertake, because I think it helps trigger additional thinking about what mistrust can look like. And this is a 17-item scale, which includes a Likert types response from strongly agree to strongly disagree. But it's taken on behalf of the patient takes this, and you can see where they think their values of the organization lie. The patient's medical needs come before other needs. I trust that the healthcare organization will tell me if something is going to happen. Sorry, having a little technical difficulty. You better be cautious when dealing with healthcare organizations. There's so many different ways that mistrust can manifest. And it can be something as simple as, my neighbor got this prescription and my doctor didn't do it. Or it can be some of these didn't do the same thing that I thought they were going to do and now I don't trust them. Or it can be these historical injustices that have, undermined trust from so many communities. Okay, next slide, please. As I mentioned before, the COVID-19 pandemic has brought several challenges related to medical mistrust and misinformation to the forefront. These are some of the possible manifestations of what that mistrust can look like. Underutilizing health and healthcare services, delaying services such as preventive or primary care services, failing to keep appointments, fill prescriptions, follow through on treatment or recommendations. There could be a myriad of reasons why this is happening, from cultural differences, misunderstandings, but mistrust could be a big one. And it also can lead to avoiding participation in clinical trials and organ donation, which further, trying to come up with the right word, further makes the system unresponsive to all of the needs and responsibilities to all of those that it serves, because it continues to represent or base decisions on data that is limited to one group. Next slide. So how do we overcome medical mistrust? I think part of it is, some of what we've talked about, understanding what it is, what it may look like, because if you can't identify it, then you can't work to mitigate it. So as we move on to the next slide, you'll see that the first item that I think is so important is identify mistrust and misinformation. figuring out what is the root cause. Is it mistrust? Is it a miscommunication? Is it a missed opportunity? Where is the patient coming from? And where is that rift coming from? And some of the ways to figure that out is understanding ways to measure mistrust and misinformation, communicating with your patients one-on-one or in community settings. There's different scales that are available to help measure mistrust, similar to the one that I shared previously. And then understanding that there are two approaches to overcoming and trying to build trust. There are interpersonal strategies to build trust, making sure that patients feel supported and respected. Employ communication strategies that are successful. We've all seen bad communication, so figuring out how do we make sure that the information that we're giving away or that we're putting out is received in the way that it is intended and people understand it. Listening to and empathizing with patient concerns and being transparent in sharing information. All too often, the healthcare system takes in information, but it becomes a black box. And we need to make sure that we share that information back, that we reflect it back to the community, let them know that we heard them, and that we're going to make adjustments so that things are tailored to their needs. And then there are also the organizational strategies to build trust, because remember, individuals can have mistrust with individuals as well as with organizations. So secure buy-in with community leaders and the leaders within your organization, because this needs to be a top-down and bottom-up sort of approach. Support and train staff so that they know how to engage and interact with individuals who may not trust the system. It may not be personal. It may be the system writ large. And then assess and address barriers to care whenever you can, and work to hire diverse workforces that represent the communities and can be responsive to the communities that you're serving. And that doesn't just mean the front line. That means everyone in the organization should be representative and inclusive of the communities that are being served. Next slide. I just wanted to highlight a couple of the resources that our office produces that can help assist organizations as well as patients mitigate issues of mistrust, improve culturally linguistically appropriate services, and better connect to and resonate with the populations that they're serving. And you can see a number of them on the screen, but we also have guides to developing a language access plan so that when individuals with limited English proficiency come into your office, you have a plan in place on how best to serve and meet their needs. Also, we have a number of resources on modernizing healthcare for individuals with disabilities. And that includes physical accessibility issues, as well as communication and sensory disabilities. So if you're blind or have low vision or deaf or hard of hearing, we have resources so that you can make those systems as responsive to them as possible. We also have a lot of data and research strategies and tools that help show where there are disparities, how you can address those disparities, and more. So with that, we'll go to the next slide, which I believe just says thank you. Thank you again so much for the opportunity to come and speak to you all today. And if we go to the next slide, you have all the resources I mentioned today are available on our website at go.cms.gov/OMH. And there's a number of ways to email us if you are have questions or in need of services. But as I promised, I wanted to get through this so that we can get over to Dawn and Derek and hear from the patients who I think are almost always the best first source of information, because they are truly the experts and know what can make this system so much better. So thank you again. And with that, I will either I don't know if I'm passing the microphone to Dawn or back to Stephanie, but thank you again for being here.
Thank you, Darcy. Yeah, thank you for that great presentation. And yeah, I think we will go ahead and start with Dawn, if you will. Dawn, kick us off to discuss a little bit of overcoming mistrust.
Good afternoon, everyone. I believe Derek and I went over our presentation, and we're going to start with Derek. He's going to set the stage, and I'll close us out. Thank you.
Okay, thank you. Thanks. Go ahead, Derek.
Okay, thank you. And thank you, Don. And thank you, Darcy. That was a lot of great information. You know, we're working on a project with the KPAC, and that's the Kidney Patient Advisory Council of the National Forum, the ESRD networks. And it's a lot of the folks that are work with the NCC and work with CMS. And there's basically in that group, there's 2 patients from every network. So there's about 18 patients roughly on the group, and we represent kind of the patient voice to CMS and the NCC, and work with a lot of other groups to improve care. And I think, you know, when we look at what Darcy was talking about, to us as we talk with each other, it's really about transparency and accountability. And it's much like building a friendship with each other. You know, if you have a friend that isn't transparent, that has another agenda, or says, hey, I'm going to take care of you, but yet you feel like you're not taken care of at the end of things, well, you build this trust. It's not a person you're going to be friends with. And so I think we experience, and I don't want to oversimplify it, but I think we experience this in our personal lives as well, and really understand, you know, what does a good relationship look like for us? And it should be that way with our medical team, you know, that they're transparent, there's no hidden agenda, and that they're accountable. When they tell us something, that's what's going to happen, and that's what we expect. And I think sometimes, you know, there's reasons that things aren't transparent. Maybe we don't understand it all, but that should be explained to us. So I was going to give you a couple examples of you know, what we're trying to do, and what you can do as a patient. So we had a situation back in 2020, close to December, where we heard a speaker talking about an Indian reservation in Network 11, which is up in South Dakota. And they shared with us that they were talking about the issues around this particular group of people had a 50% COVID rate on the reservation. They were in dire need of help. Their dialysis groups had 20% of the dialysis patients had COVID. Yet they did not have safety equipment, masks, gloves. They had run out of all these things. And so the network had reached out to Indian Health Services, had reached out. Things were moving very slow. They were like, well, we have a shortage of masks, even in our clinics. And so there was about 400, a little over 400 patients, ESRD patients there. And so we, you know, talked about this quickly and said, Matt, I just can't imagine, right, at this point in time, that I go into a clinic and they're like, well, either hang on to your mask because you're going to need to use it for the next few weeks, or we don't have one, or we don't have gloves, or your technician doesn't have gloves or gowns or what have you. And so we as patients, and I representing the KPAC, reached out to Davita and Fresenius and their upper management and said, look, here's a problem. We have these patients. They don't have access to safety supplies. We just shined a light on this situation and said, you know, and kind of explained, wow, if this was us, you know, I can't imagine the difficulties they're going through and how, you know, frightening that would be. And so we got responses from both companies, Davita and Fresenius. Matter of fact, late that evening, I think I received an email about 11 o'clock. We were still shooting emails back and forth. Within 2 days, they got all the supplies they needed. And they had said, they would pay for the supplies. It wasn't that they couldn't pay for them. It was they just didn't have access. So anyway, long story short, they were all, they're actually given some supplies to just cut through all the red tape to start with, to bring them up to speed. And then actually Fresenius was due to the fact they manufacture some things, we're able to set up a way for them to have regular access to safety equipment at a more affordable rate than they were actually giving. So there was a long-term solution. So I think many times we as patients, I feel, have a responsibility, because this isn't really, whether you fall into one of these groups, I'm not Native American, but this is about the human race, and this is about humanity. And I think for those of us who see what's going on in our clinics, we see what's going on with each other, have a responsibility to shine a light, to speak up. If you see something, say something. I know we hear a lot of that in different regards lately, but I think it's so important that we're there for each other, that we lift each other up, no matter our background or where we live or where we come from or how much money we make, that we all deserve equal access to care. We deserve to be told about, educated about our healthcare choices and how they best match our lifestyle, kind of get a treatment that matches you. So anyway, so that's kind of what started us started me to get very enlightened about what's going on, and that we had to make a change. And I wanted to share with you quickly something I heard at the CMS Quality Conference that I thought was very interesting. And you're going to hear more from CMS about gathering data and breaking things down and trying to understand where these gaps and disparities are. But this particular example was shared by Dr. Sumit Mohan, and he's a nephrologist, transplant nephrologist in New York. And he shared talking about steps to getting a transplant. And he talked about each step and broke it down. So when you look at getting started with an evaluation, there's a disparity there. 61% of white people get to that point of getting an evaluation, where only 52% of Black patients achieve that. But then when you go to actually looking about completing the evaluation, there's only a 1% difference. So you're like, okay, well, that's good. There's some equality there. But then when you jump down to the next step of getting waitlisted, there's an 11% difference. 71% of white people are waitlisted, and 60% of Black people are waitlisted. There's no real data that tells you within these steps why this is occurring. So we know it's been happening. We know these disparities are there. We've known for decades we have disparities, and we keep track of those. But yet we don't dig in and lift up and really get that data to say, what's wrong with this situation? We don't shine a light to say, okay, we know this is happening, but why? What's broken in this? And then if you look at actually people getting transplanted, there is 12% difference. So 30% of white patients get actual transplant, and only 18% of Black patients get a transplant. Why? We can guess, but we don't really know the data and why that is. If you look over at other information you shared, days needed for completion, when you look at waitlisting to transplant, we have 374 days for average for a white patient and 727 days for a Black patient. Why? We don't have the data to dig in to know why is this disparity there. So I think the important thing to start with is to shine a light and say, lift up the lid, look at the good, the bad, and the ugly, and say, why is this happening? What do we need to change? What do we need to do better? And I think, we as patients have a strong voice. Even just one patient has a strong voice to speak up and say, this isn't right. We need to fix this. We need to shine a light on this. This was my experience, and maybe my experience was good, or maybe my experience was bad. And this is my neighbor's experience, or my friend's experience, or something I saw at a dialysis center that I thought, wow, that's just not right. We have an obligation to speak up and not necessarily get angry, but be part of the solution and speak up and say, okay, what can we do better? So we all have equal access to care, so we all get a shot at that transplant. I think if one of us isn't it falls behind, then it's a failure on not only the system, but all of us as people and patients, that we need to lift each other up. I know Dawn will be talking about her transplant experience, and talking about a resource, a health equity toolkit that the KPAC has been working on, and it's taken us quite a while, but much of what the experiences are with the patients reflect what we've seen. For example, for Native Americans, I mean, this is not one single problem. This is a problem across our country. And not only what we see here in the data, and I should have shared this with you, this chart, but what I'm seeing in front of me, there's lived experiences out there that show that that our system isn't equal. That I think it was Gail Sage that shared, and she's a patient, and I believe from Minnesota, but I may be wrong. But she shared during the quality conference that she was getting care through a reservation and not having the same equal access to the same doctors even for care for her diabetes, and she wasn't able to manage it well. She ended up in kidney failure. She was only offered in-center dialysis. She heard of home dialysis through Facebook. So there she's going outside to find out about it. In order to get on home dialysis, her sister luckily was able to drive her over 2 hours to the nearest home dialysis center and then take her back. And so she was able to get on home dialysis, and her life improved, her health improved, and she finally got transplanted. But she said she overcame things that were nearly impossible for most people who lived in that area. They don't have transportation. They don't have someone willing to drive them 2 hours each way to get access to care. So we have people that live in very rural situations that we need to shine a light on that and say, well, what can we do better? How can we make sure they have access to care, to home dialysis, to a road to transplant? And if we don't have that, what do we need to change? So I think, like I said, it's imperative for all of us to take this to heart, to lift each other up. And I will turn it over to Don to kind of sum this up and maybe talk a little bit more about the tool that we should have out in the next couple of months. So Don, I'll turn it over to you.
Thank you so much, Derek. And I want to thank Darcy for really setting the stage for us and giving us some great examples of what has transpired in the past and how we got to the point that we're at today. And I also want to thank Derek for giving us those great examples of what is really going on. It's still going on now that causes some problems in patients getting access to the care that we want. And we know that this is what causes the mistrust that exists in the medical care that we receive. But I really wanted to one, just to talk really briefly about my experience with trying to get transplant listed as an African American woman in New York City. Um, I attempted to list at one organization or one facility. I went for the interview. I went for the blood work and everything, and then I didn't hear anything from them for a year. And I said, this is a whole year that I'm wasting. And I talked to another facility about getting listed at their facility, and they were so excited. They said, of course, and now that I've switched over and transferred to this new facility, the transplant coordinators calling me regularly. They brought me in for the evaluation. They've started the evaluation testing process. I've had several tests done already. I've already seen a transplant specialist that specializes in difficult transplants. So I'm getting something done. So that just shows how you can have a difference in one facility to the other. So if you aren't satisfied with one facility, patients have to be empowered to move to another facility because things like that make us not trust the healthcare system. So that's just another example, and also encouragement to our patients that if you aren't satisfied with one facility, if you can, you know, move to another one so that you can get the care that you deserve and that you want. So I really don't want to talk about the problems. We know that the problems exist. We know the history of the problems. We know about medical mistrust. I wanted to talk about solutions. How can our providers earn trust in with their patients in medicine? Well, the first step with anything, and I tell patients, the first step into getting control over a situation is getting yourself educated. I say the same for our medical providers. There are so many tools out there. Darcy mentioned several from the Office of Minority Health that can help providers get educated. Maybe they don't even realize that the practices that they're using or the style of communication that they are using with their patients is causing this medical mistrust. So Darcy mentioned many resources within the Office of Minority Health that providers can use so that they can learn how to effectively communicate with a patient so that the right ideas and that shared decision making process can take place between the provider and the patient. That builds trust. A patient needs to know that they are being provided with all of their options so that they can be discussed in a manner that the patient understands and that a decision can be made between the provider and the patient that is shared between the two so that the patient feels sure that they are choosing the best option for themselves. So I say to our medical community, educate yourself. Our KPAC, the Forum of ESRD Networks Kidney Patient Advisory Council, is developing a toolkit specifically for the ESRD community. Hold on to your seats. We're working on this toolkit, and it will be coming out within the next couple of months or so, where we're actually presenting actual scenarios which have taken place within the lives of ESRD patients along their kidney journey and solutions to how to remedy these missteps in working with a patient and communicating with patients to help them along their journey. Also, there's a really important tool out there that I don't think the medical community is quite taken hold of yet the way that they should. There are many organizations that are utilizing them and seeing huge success, and that's the use of advocates. Advocates are able to communicate in a way to patients that our medical community and our medical professionals are just not able to do. There needs to be more advocates on the floors in dialysis centers. Advocates need to be in every aspect of the planning of care for patients and the delivery of care for patients. We are excellent communicators. We are able to translate from one language to another. And we're able to overcome some of those language barriers from clinical information into practical dialogue that patients can understand and utilize so that they can so that that can help them in their decision making. and take advantage of educational efforts like what is being put forward today, like educational efforts from our other stakeholders, and learn as much as you can so that you as providers can provide patients with all of the options that are available to them so that that shared decision process can be taking place. If the patient doesn't feel that you know enough about your field, then they're not going to trust the care that you're providing them with. So these are just some of the things that our providers can do to help and earn trust. And I'm going to finally sum it up by talking about some things that our providers can do to promote trust between provide care with too. And one of the main things Derek mentioned early in his talk is transparency. Patients need to know that transparency is taking place between the provider and the patient. With COVID-19, there was a lot of misinformation going forth. We weren't able to see data that we really needed to see to keep ourselves safe and protected. And that's why we have a lot of problems with patients getting vaccinated and a lot of patients not trusting the vaccine because we really haven't had the transparency and the data that we need. And this goes forth with, throughout healthcare, with all aspects of healthcare. Patients need to see data too. That helps us to make decisions. I saw a comment from my good friend here in New York, Stephanie Dixon, who mentioned in the chat about the clinic's star ratings and quick scores. We need to see those so that we can make a decision about the facility that we choose to go to. The standards have been set, and those need to be followed to the letter so that patients can see the adequacy or to see the scores of the facilities that they choose so that they can make the right decision about whether this facility is right for them. So transparency is key to this. Whether it's good or bad, we can deal with that together as a community. We know that in some areas things aren't as good as far as quality as others, but we need to see that and that we can make the necessary adjustments and address it and make those changes so that we can have equitable health care. Another one of the things is that providers need to speak in that language that patients understand. Clinical jargon doesn't work for patients. We don't understand it and we can't follow the medical advice that you want us to follow. So if you can't speak in the language that we understand, utilize advocates, utilize your staff members, but make sure that the patient understands what it is that's being conveyed to them so we can follow the medical advice and we can achieve the outcomes that you expect. The next thing is accountability. We have failed to take accountability for the things that have happened in the past and are consistently going on in the present. And we need that accountability to come forth so that we can deal with the problems that are taking place, accept what has happened, and move forward. That is one of the steps that needs to be taken in order for us to advance in healthcare and to build that trust that patients need to have in their providers. And finally, I would say to use patients as partners. Patients have to be your partner. Derek talked about building a friendship between providers and patients, and that is necessary for patients to be able to have the open dialogue that's necessary between the patient and providers, and listen to what your patients say. We don't trust when we tell you that this hurts or we need this attended to, and our provider is not an active listener into the things that we need as patients, and they're not being addressed. So at that point, I'm going to stop. Thank you so much for listening to me, but I hope that our patients and our providers got something out of our presentation today. Thank you so much, everyone.
Thank you, Dawn.